Iron deficiency anemia. Stages of iron deficiency anemia. There are three stages. The first is negative iron balance, in which the demands for the iron exceed the body's ability to absorb iron from the diet, which results from blood loss, pregnancy, rapid growth spurts in adolescent, or inadequate dietary intake of iron. We can mainly see decreased ferritin, normal iron, TIBC is also normal, RBC and protoporphyrin are increased in the case of iron deficiency anemia in the stage of negative iron balance. The second is iron deficiency erythropoiesis. Once the transferrin saturation falls to 15 to 20%, hemoglobin synthesis becomes impaired. This is the period of iron deficient erythropoiesis. First appearance of macrocytic cells, hypochromic reticulocytes in the circulation are seen in this stage. In this, we can see serum iron decreases and protoporphyrin increases. Iron deficiency anemia. Gradually, the hemoglobin and the hematocrit begin to fall, reflecting the iron deficiency anemia. The transferrin saturation at this point is 10 to 15%, and here finally we can also see macrocytic and hypochromic anemia. In the clinical presentation of iron deficiency anemia, signs related to iron deficiency are fatigue, pallor, reduced exercise capacity, cheilosis, which is the fissures at the corners of the mouth, and koilonychia, which are the spooning of fingernails. Now, laboratory iron studies. The first is serum iron and total iron binding capacity, also known as TIBC. The serum iron level represents the amount of circulating iron bound to transferrin. The TIBC is an indirect measure of the circulating transferrin. Transferrin saturation in the case of iron deficiency states is associated with saturations of transferrin receptors at the levels below 20%. The second is serum ferritin, and one of the most important. Within the cells, iron is stored complexed to the protein as ferritin or hemosiderin. The normal value for ferritin varies according to the age and gender of the individual. Like in adult male, ferritin values average about 100 microgram per liter, whereas in adult females have levels averaging about 30 microgram per liter. Third is evaluation of bone marrow iron stores. Iron stores can be estimated from the iron stain of the bone marrow aspirate or biopsy. The fourth is red cell protoporphyrin levels. Under conditions in which heme synthesis is impaired, protoporphyrin accumulates within the red cell. This reflects an inadequate iron supply to erythroid precursors to support hemoglobin synthesis. Now, the differential diagnosis of iron deficiency anemia. First of it is inherited defect in globin chain synthesis, the thalassemias. These are differentiated from the iron deficiency anemia by serum iron values. Normal or increased serum iron levels and transferrin saturation are characteristics for thalassemia. The red blood cell distribution width, also known as RDW index, is generally normal in thalassemia and elevated in iron deficiency. The second is anemia of inflammation. Usually AI or anemia of inflammation is normocytic and normochromic, whereas iron deficiency anemia is hypochromic and macrocytic. As the ferritin level is normal or increased and the percentage transferrin saturation and TIBC are typically below normal for this. The third is myelodysplastic syndromes. Patients with myelodysplasia have impaired hemoglobin synthesis with mitochondrial dysfunction, resulting in impaired iron incorporation into heme. The iron values again reveal normal stores. Now, the treatment for iron deficiency anemia. The first is red cell transfusion. This red cell transfusion is reserved for individuals who have symptoms of anemia, cardiovascular instability, and continued and excessive blood loss. The second is oral iron therapy. Ideally, oral iron preparation should be taken on an empty stomach since food may inhibit the iron absorption. Some patients with gastric disease or prior gastric surgery require a special treatment with iron solutions because the retention capacity of stomach may be reduced in this kind of patients. The goal of the therapy in individuals with iron deficiency anemia is not only to repair the anemia but also to provide stores of at least zero point 0.5 to 1 gram of iron. Sustained treatment for a period of 6 to 12 months after correction of the anemia will be necessary to achieve this. The third is parenteral iron therapy. Intravenous iron can be given to patients who are unable to tolerate oral iron. Parenteral iron is used in two ways. One is to administer the total dose of iron required to correct the hemoglobin deficit and provide the patient with at least 500 mg of iron stores. And the second is to give repeated small doses of parenteral iron over a protracted period of time. Drugs used in the parenteral iron therapy are ferrous sulfate, ferrous gluconate, ferrous fumarate. In administering intravenous iron dextrans, anaphylaxis is a concern. Generalized symptoms like arthralgias, skin rash, and low-grade fever are seen. If large dose of iron dextran is to be given, that is more than 100 mg, the iron preparation should be diluted in 5% dextrose in the water or 0.9% NaCl solution. The iron solution can then be infused over a 60 to 90-minute period for a larger doses. Here's your host, Clinical Swott, signing off. Stay tuned, study hard.